Good afternoon. Welcome, everyone. I'm Cheyenne Corbett, Director of Cancer Support and Survivorship at the Duke Cancer Institute. Today, as part of our Survivorship Day event, we are hosting this live panel as an opportunity for our Duke and broader community to ask questions about living with and beyond cancer. This is also an opportunity for us to learn from your questions. At the Duke Cancer Institute, our mission is to discover, develop, and deliver the future of cancer care now. We have incredible researchers, doctors, and nurses providing cancer care to patients every day. We also have a comprehensive cancer support and survivorship team who provide vital services throughout the cancer experience, from time of cancer screening, diagnosis, treatment, end of life, or survivorship. And we provide this care not only to patients, but also their loved ones. There's no other cancer center where you'll find such an incredibly talented and caring group of people who together, in their research, training, and clinical care, discover, develop, and deliver the future of cancer care now. Today, our panel includes several experts in their fields who are part of our cancer support and survivorship programs. Daily, they take the science of cancer care and translate that to personalized education and services for you. They will be answering questions that have been submitted in advance, as well as questions you submit live during the hour. Thank you to those who shared questions ahead of time. I also invite everyone to submit any questions live through the Q&A function at the bottom of your screen throughout today's event. For those who are new to the webinar format on Zoom, the chat function is disabled for this session, but the Q&A button you see at the bottom of your screen is active. Click on that button and you will be able to ask your questions. Questions will be asked anonymously, so please use this opportunity to ask any questions you have for the team. And now I want to introduce our panel. Dr. Karan Vyas is a member of our psychiatry team. Dr. Vyas provides mental health care to our patients. He has specialized expertise in behavioral interventions and medication management during cancer care and survivorship. Dr. Kevin Effinger is a physician who specializes in survivorship care and is a world-renowned researcher in the fields of cancer survivorship and onco-primary care. In his research and clinical care, he works to create collaborations with primary care providers across the cancer continuum from screening to survivorship and to ensure cancer survivors receive the highest quality care. Lisa Massa is a physical therapist and coordinator of clinical services for oncology. She and her team provide interventions to help people get through cancer treatment and thrive into survivorship. Her team helps with mobility and physical activity, as well as survivorship concerns such as sexual health or lymphedema. Paige Fisher-Strino is a dietitian on our team. She's a certified specialist in oncology nutrition. She and her colleagues work with patients and families during and after treatment to understand their nutrition needs at the different phases of your care, as well as advise on practical ways to adapt what and how you eat. Valerie Worthy is, with her expertise as a former home care and hospice nurse and oncology treatment nurse, Valerie now leads our patient navigation program. She's an engaged community member who strives to reduce barriers to care and ensure patients' needs are identified and met during their care with support from members of the patient navigation team. As we begin our session today, I'll turn to each panel member to start off with you describing a common question you receive and how you answer that for your patients. Let's start with Dr. Effinger. Kevin, what is one of the most common questions you receive from people about survivorship care?
Rather than saying question, what I often tell my patients is that there is no such thing as a dumb question. I try to include that in every new patient visit because a lot of times our cancer survivors will feel a little bit like a hypochondriac. They'll complain of something that they're really having a hard time articulating. I always tell them, you know your body, you know what you've gone through, and if you have a question, you let us know and we'll do our best in sorting it out. So I think the key point again is that there is no such thing as a dumb question.
Thank you. Dr. Vyas, how about you? What's a common question that you receive and how do you answer that for your patients?
One of the most common questions that I receive from cancer survivors, maybe a year or 2 year out of their treatment, active treatment, is why am I still feeling this sense of worry and fear and anxiety about what's going to happen next? And I just try and tell them to listen to their emotions, and because it's very common and natural to feel a sense of uncertainty when there's no structure of the active treatment. I would also ask them to identify what are the barriers of living well in survivorship, because survivorship is about thriving from the illness. And so one of the common question I get and the answer that I give is listen to their own emotions and seek out help with the help of the Duke Cancer Support Team or their mental health provider.
Thank you, Curran. That's very helpful. And Paige, how about you? What's a common question that patients or families ask you or your colleagues on the dietitian team?
I think a lot of the questions that we receive are about why do I still feel this way? I think that's pretty much across the spectrum of someone that's a survivor. But oftentimes, I like to tell survivors that, you're different from everyone else, even if we've all gotten the same type of treatment. How your body responds is dependent on what your nutrition status was at baseline, what your physical activity was at baseline, and to give yourself some grace to heal at your own pace. And it's great to get advice and listen to other survivors, but you are going to heal and you are going to get better and on your own timeline.
Thank you, Paige. And Valerie, how about you? What's a common question you and our patient navigators receive?
So while patient navigation isn't a new concept, it was old. It started in the 90s. Many of our cancer centers now are beginning to embrace patient navigation. So many of our patients want to know how they can get connected to navigation services. And so I explained to them that it's your oncologist, your nurse, any of the healthcare professionals, and even people out in the community can make to patient navigation.
Thank you, Valerie. And Lisa, how about you and the physical therapy team? What's a common question that you receive? Oh, you're on mute, sorry.
Okay. Sorry about that. Similar to some of my other colleagues' comments, I think one of the things we often get is it realistic to expect that I can get back to the activities I enjoyed the most before my cancer diagnosis? Is it safe for me to do these activities? What can I expect of myself now? What is the new normal, and when can I push myself to expect more of my body from physical activity? And fortunately, more often than not, the answer is yes, you can return to those activities. It just may take some modification or adaptations initially to get yourself started.
Thank you, Lisa. So we have questions that have been coming in from the participants today. And the first one I'll direct to you, I think, Kevin, and that is, what can I do to lower my risk of my cancer coming back after treatments?
It's a great question. And again, that's one of the most common questions. I often show a slide when I am talking to survivorship groups that said, if I had a pill that lowered the risk of having recurrence of 17 different cancers, having heart attacks, strokes, diabetes, cholesterol problems with your blood pressure, and Alzheimer's, and has been shown positively in study after study, would you take it? Of course, the obvious answer is yes. And that's exercise. It's walking, simple walking. 30 minutes, 5 times a day, has been studied both in the general population in prevention of cancer, but also in our cancer survivors, most notably among breast cancer survivors, but among other groups too. So walking at a brisk pace, enough for women to glisten, 30 minutes, 5 days a week, that's the most important thing one can do. And then, as Paige would say, also a good diet. And I'll let her comment on what a good diet is following cancer.
Thank you. Actually, I'd love to hear from Paige and from Lisa about some additional information about that. Paige, what are your thoughts about nutrition?
So that's an excellent point. I mean, everyone wants to know what is it that's going to prevent cancer, or what is it, but what we have that's evidence-based is that people, survivors and people that are in just the general population, eating a Mediterranean or plant-based diet is what we know. It helps prevent, certain cancers like breast cancer, prostate cancer, colorectal cancer. So that doesn't mean that you're a vegan or vegetarian, but it just means that you are eating foods that are plants. So grains, vegetables, fruits, nuts, seeds, because these foods are very high in nutrients. They're high in protein, high in fiber, but they're very low in saturated fat. And that is good for prevention of heart disease, for diabetes, prevention of stroke, and also certain cancers. So it's just really about getting more plants in your diet and getting creative with that. Throw out traditional food rules. If you feel like you're going to want to have a salad at breakfast, just do it. And I tell everybody to start slow because it can be overwhelming, but aiming to get those 5 to 10 servings of vegetable and fruit per day, and working on, lowering your amount of red meat and highly processed foods.
Thanks, Paige. Lisa, to that point, sometimes people have questions about beginning to increase physical activity, even getting to 5 minutes of walking when they feel fatigued, or they have other concerns. What are some practical steps that people can take when they start out trying to increase their level of physical activity, to Kevin's point?
Yeah, so I think the first question I always like to ask folks is, what is it that you like to do, right? So some people enjoy walking, and so that's a great exercise. But if you're a swimmer, then swim. If you're a cyclist, then ride a bike. And the other thing is I think some people do better if they can find things in a group format, whether that's joining a gym or there's so many options now online for group exercise programs. And not to mention the virtual reality-based programs like with the mirror, where you hang it up in your room, your house, and they have somebody walking you through all the exercises you need to do. But the thing is to make it fun and to keep it interesting for yourself, because boredom will kill most people's incentive to do anything after an extended period of time. So mix it up. I like to encourage folks not only to do the aerobic piece, but also strength training. I think strength training is undervalued by some of our survivors, partly because we don't educate enough on it. But I think that can be a great way to vary your exercise routine, as well as improve your overall physical function.
Thanks, Lisa. We had a question now with people getting out a little bit more, starting to sort of, as we're approaching a different phase of our COVID experience. There's a question that's come through about how to deal with social anxiety post-COVID. Still nervous about being out, being active, even though they're vaccinated. What would you have in terms of feedback for that person, perhaps Dr. Bias?
We are still recovering from a year-long period of uncertainty. So everybody will have their own timeline. There will be, what I would recommend to the patients who are experiencing social anxiety from going out is, some of it is also not your own creation. Some of it is also very natural and normative to feel that way after you've been stuck inside for a year. So I would recommend to sort of listen to their gut and not really force themselves into situations that will worsen or make them even more anxious. So I would recommend to just give themselves time and have some patience, and over a period of, as things start opening up again, their relationship to going out might change, because we are used to being inside for a long time. And so I would just recommend some patience, and your body will adapt to it and your mind will adapt to it.
Cheyenne, if I can add to that too, which I think that's right on target, is our psychology group that works with Dr. Bias is extremely proficient in teaching cognitive behavioral therapy, which I always think of as something that helps us put some boundaries around our unhealthy emotions, our fears, our sense of uncertainty, things that creep into our sleep patterns and cause insomnia, et cetera. And so they're very good at working with our cancer patients, both on therapy and of course our long-term survivors, in helping to reduce some of those. And that includes post-COVID anxiety of getting back into the place. I'm gonna emphasize what Dr. Weiss said is you are yourself. You are the one that makes that decision. And you get back into things at the pace that you want to, not at the pace that somebody else thinks you should.
Thanks, Kevin. Valerie, I wonder about what questions the navigators receive when it comes to this type of question in the community, what they might be hearing from peers, and what you recommend to them in terms of education that they should seek from their provider, or how a navigator can help them as well during this time.
So many of our patients were afraid to even come back to our cancer center. And so getting that information out to the community isn't coming to us, was vitally important. And so I just began spreading the word out in our community. We also used our support groups that we have at Duke to get the word out that our cancer centers were safe. Even when it came, Cheyenne, to people getting their regular screening, our screenings were down. And again, we all had to come together and get the messages out as quickly and as efficiently as we could, so that people would not miss their screening and then come back in our cancer center with new cancers. So people were frightened. Even those that were getting treatment were a little hesitant about coming in. But I think just by calling people, reassuring them, and making sure that they knew that we were available to answer questions and connect them to any resources that we could help many of us.
Thank you, Valerie. That's really helpful. And we get that question about screening a lot. This last year has been very challenging in a lot of ways. And one you mentioned, Valerie, is people wondering whether it's safe to go and participate in their cancer screenings, and what difference it makes for them if they wait. And I wonder, Kevin, if you could mention about the importance of cancer screening and in the survivorship phase, but especially now.
I think, first of all, our cancer centers and our imaging centers have taken the safety of the patients very seriously. We try to keep the environment as safe as you can for getting back into cancer screening. It is very important. It's not uncommon for us to see somebody that's gone 6 months, 8 months beyond the time period which we would typically screen, and we pick up something that's important. So just encourage our patients to get back on track with that, get back into a screening routine, get back into a regular exercise and diet pattern, get back to a normal sense of life.
Thank you. We have another question about cancer-related fatigue and exercise and nutrition. And there's some specific questions around what ways can you help decrease fatigue that somebody might be experiencing and increase their energy throughout the day. I think what I hear from patients a lot is when they're feeling fatigued, they feel like not being more physically active, when we know that being more physically active is helpful. How do you advise people about that, Lisa?
So I think one of the things I like to do with patients who are experiencing fatigue is to have them do some journaling to see if there's a specific time of day where it's at its worst. Are they someone that gets a slow start in the morning, or is it like by 2 o'clock in the afternoon, they're just wiped out for a few hours? And then try to pick the peak times of energy as the time to then exercise. Because as you said, Cheyenne, we definitely have shown that when exercise is done on a regular basis, it actually diminishes the feeling of fatigue overall. But you need to capitalize on your peaks and not focus on the valleys quite so much. So that's one of the things I'll suggest to folks. And I absolutely agree with Dr. Eppinger, 5 days a week of 30 minutes of exercise would be great. But if you're feeling really tired, you can start with 3 days a week of 15 minutes. Set, attainable goals early on so you can feel a sense of accomplishment, and journal about it. So, I did 15 minutes of walking on Monday. Maybe on Wednesday, you'll try 20 minutes if you feel up to it, or do something else, but start to journal so you can see your own progress. Because I think a lot of patients, I think it's true of all of us, we sometimes forget how far we've come because we're still focused on the things we still can't do or that we'd like to see change. So that would be some of my suggestions.
Thank you. I'd like to also ask Curran, what from the psychiatry team members, when we talk about fatigue or motivation, what are suggestions you have for people who are feeling that fatigue and wanting to increase their activity and feel less fatigued during their day?
That's an excellent question, and one of the more common questions that patients ask me is, why am I feeling so tired? Why am I feeling foggy? And it becomes extremely difficult when patients are just trying to get back to their regular lives after the treatment is over, whether be it regular family life, whether be it returning to work. And all these barriers can really disrupt one's life and cause a lot of distress. There's a good chance that after radiation, possibly surgery or chemotherapy, your body and your mind has probably changed a little bit. And so what I suggest patients do is, just like Dr. Atkinson just said, exercising goes a long way in helping with fatigue. The other sort of evidence-based treatments that have shown good outcomes is relaxation. So having some sort of a mindfulness practice, whether be it phone-based applications like Headspace or Calm, or having your own sort of a mindfulness-based practice goes a long way. Having brain training programs has shown efficacy. So doing Sudoku, things like that, or Lumosity, those little exercises that are there really help a long way. Other thing that really help is pharmacological based therapy. So if, in spite of doing all these things, exercise, diet, relaxation, if you continue to have problems at work or at home, then there are certain pharmacological therapies or treatments that can help these patients gain some of that functionality back. Things like stimulants, armodafinil or Nuvigil or Provigil can sometimes be appropriate for certain patients. And so it's not just one thing, it's a sort of a gamut of interventions, whether be it behavioral or pharmacological, that can help with these conditions. And also, I would say the same thing with chemo brain, what people commonly say with chemo brain or cancer or cognitive cancer-induced cognitive dysfunction. I would say same recommendations help with that condition as well.
Cheyenne, if I could just add a brief comment. So
Yes.
one thing our occupational therapists here do is cognitive rehab. So this is another avenue for folks who are having the chemo brain or the chemomnesia.
Mhm.
If someone feels they need a structured program to kind of address their symptoms, that is something that our occupational therapy does routinely.
Thanks, Lisa. I think that's an people don't know that is available to them and the benefits of OT for those purposes. So thank you for bringing that up. Absolutely. And
Hey,
I wonder
Cheyenne,
about, yeah, go ahead, Paige.
So as far as nutrition, I just want to also, when I meet with patients and I meet with survivors, I tell them to be kind to themselves because fatigue is the #1 side effect of all cancer treatment. So you're not going to have that same level of stamina that you normally have, even, 3 months, 6 months after treatment. Again, movement is the #1 thing you can do, and it also helps with certain side effects that you may have from treatment or previous treatment. It can help stimulate your appetite. It can help with post-meal nausea or heartburn. It can also really help with constipation. So getting that physical activity in. And then also, if you see that your diet has been lacking in some ways, you can always talk to your provider about getting certain vitamins or certain labs checked and, talk about certain, specific supplementation for you, but just trying to get a nice balanced diet with good amounts of lean and plant-based proteins and all those colorful vegetables and fruit, because those B vitamins are super important.
I have 2 questions for Valerie, but one follows directly to that page. A lot of people talk about knowing what they should be doing and then the challenges of actually implementing those changes in a day-to-day basis. And I think people think if you could answer how to access healthy foods in a way that is not cost prohibitive for people. I think people can be overwhelmed with that potentially being very expensive, or where do they find those foods? So if you can give some practical tips on what people can do and or where they should go.
So I think a large part of it is a societal problem where we think that, you know, we have to eat clean and we have to eat organic, and there's all these different, you know, morality associated with food, but it's really just about anything can be helpful for you. Getting a can of beans, you know, getting, you know, a head of lettuce from the outside, some lean chicken, eating those things from a, you know, you don't have to eat in a certain way just because some influencer tells you this is the way to do it or this is the diet that they follow. But really meeting with a dietitian, meeting with a provider, and getting a plan that is specific for you. But healthy eating is available to everyone. You know, everybody always asks me about, should I eat organic? Should I avoid this? Should I get pasture raised, this and that? And that is a totally personal question. But really, there's no evidence-based recommendation saying that you have to eat clean or organic. It's really just about getting plants in, fruits, vegetables, grains.
Thank you. That's really helpful. And Val, that leads me to a question that I have for you. Oftentimes people might not want to bring up to their doctor or their nurse some of the questions that they have or concerns that they have. What role would either a nurse navigator or patient navigator play for a patient in terms of that extra layer of education and support for them, especially around topics that they might not know to bring up to their provider, or maybe initially want to bring up to their provider?
So Cheyenne, that's a great question. So I find that patients go from one spectrum to the other. Either they have no questions or they have too many questions. And so in both cases, as a navigator, we try to help them to answer the questions that cause them the most stress and angst, and they're not able to sleep at night because of them. And then when patients have a lot of questions, then we also help them to prioritize. Oftentimes patients will say, well, I don't want to worry the doctor. And so, you know, I don't want to ask all these questions. Or either after the oncologist has explained the diagnosis and the treatment, and then he'll ask, are there any questions? And they'll say no. And in the minute that they leave, they'll turn to me and ask me the question. So oftentimes it's just good to kind of prepare our patients on what questions to ask and what is the most important thing for them. Because when they go back home, they'll have to recite all of this to their family members. So we want to make sure that they're prepared and they also become informed consumers.
Thank you, Valerie. We have a few questions coming in about the role of caregivers. And there's a question that says, my partner was diagnosed with lung cancer recently, and I'm feeling overwhelmed. Can you tell me about what caregivers should pay attention for in themselves, as well as how they can help their loved one? Kevin, would you mind starting perhaps with that question?
Actually, I see Dr. Bias nodding.
He was
I'm gonna
nodding,
let
I
him
noticed.
start.
Curran, how about you?
Caregivers play a crucial role in the cancer journey that the patients go through. They are the ones that know how cancer has intimately affected patients' lives, because they have to put their lives on hold as well to take care of their loved ones. And a lot of times, the caregivers are not upfront about what their needs are and how they can be really helpful and play an active role in the cancer care. And a lot of times they have to make adjustments that are long-term while the patient is actually going through cancer treatments. And so what I would recommend is try and advocate for yourself and make yourself an important part of the care team. Try and try to advocate and reach out to the cancer support program, whether it be the Duke or any other cancer program, and see what kind of support and services are available for caregivers, whether it be support groups, whether it be it other sort of behavioral interventions and or intermittent therapy for your own self. An important aspect is just practicing self-care and identifying your own needs as you sort of embark on this journey.
Cheyenne, another thing that I say to our patients is know who the people are in your life. So for our caregivers, oftentimes they want to take on everything. So they want to be the person that accompanies the patient to the appointment, the person that does the cooking, the laundry, everything. But there are so many people that want to help and they don't know what to ask for. And so divvy some of those responsibilities that other people want to do to other people. And I think that takes some of the stress off of our caregivers. But we have to tell them that because, you know, there's not a book that says this is how you be a cancer survivor and this is how you be a caregiver. So as professionals, we help our patients to divvy off some of these responsibilities as well as our caregivers.
So can you speak a little bit more about that, Valerie? And I'd love input from others as well, but how do you divvy that off? How do you ask for help or reach out to your friends or loved ones for their assistance? What are some things? Because I know people often don't want to ask for help or be a burden. They feel like they're being a burden to others. What would you say to that?
So I always say that people really want to help and help people help you. What are some of the things that you would like to do that you can't do right now? And it could be just really small things. And when people do small things, they really think that they're helping you with your cancer, that they're part of the cancer team. And so even going to the mailbox and getting your mail, people are really excited that they have helped another person, you know, during their cancer journey. And so I say to our patients, don't deprive them of this. They really do want to be a part of your care. And the other piece is I say to patients, know who the people are in your life. So if you've got a caregiver and their focus is actually your care, then don't expect them to be the cheerleader, the singer, the cook, and all of that. Like, that's not going to happen and that's too much for them. But there are people in your community, your church, in your civic organizations that would love to be a part of that. And oftentimes you need to outline some of the things that you know you do in your normal day just to be able to make it. And that is so helpful to people. They're not thinking in that way. They're just thinking about living and surviving. So some of the smaller tasks, we help them to determine what's important to them.
Thank you. And Paige and Lisa, I wonder, as caregivers feel that feeling of being overwhelmed, or they're working with their loved one to create changes in their lives because of their treatment, et cetera, what recommendations do you have for them as loved ones for what they should be, could be focusing on for themselves as well during that time?
So I think sometimes caregivers feel guilty, especially when someone's going through treatment. They're having these nutrition issues they don't want to eat. Maybe, you know, the smell of food is bothersome, the look, the taste. They sometimes get really down and out about a food that the patient, their loved one, really likes. It's totally disgusting right now. And I just try to tell them to put those feelings on the shelf because cancer is changing the way that you perceive food, your desire for food, the way food tastes. So, don't think of yourself as a short order cook. Just always remember to take care of yourself, make food that you like, and try to be accommodating. But as far as like asking for help, is what Valerie was saying. In the South, I know we'd love to give a hot meal and some casseroles and stuff like that for somebody going through treatment. But a great thing to tell a friend, a church member, a coworker, please groceries for me, because going through cancer treatment or as a survivor, your appetite, what you want to eat, the amount that you want to eat is going to change. So having someone do something tangible instead of bringing over a giant lasagna that you're going to throw away in 4 days is really helpful. So, reach out, give them tangible lists are awesome. So take advantage of that.
Thank you. Lisa?
I think one of the things I like to point out to the caregivers is that a lot of times the things that they're experiencing, changes in sleep, stress, difficulty focusing, also benefit from exercise. So whether it's something they do with their partner that they're caring for, or they do something separate for themselves, because it's been said before, but they do need to take care of themselves as well as taking care of other people. So sometimes if they both enjoy the same type of activities, doing that together can be kind of a fun thing, I think, and something that takes away from the treatment part. Or also recognizing that to be a good caregiver doesn't mean you have to be available 24/7, 365. You are allowed to set aside time for yourself to do the things that keep you healthy and well, both physically and mentally. And again, the same idea is, what do you enjoy doing? What is comfortable for you? Would be the same suggestions that I would give the caregivers I give the patient.
Thank you. Kevin, we've had some questions come in about what role does primary care play in survivorship phase, and can you explain a little bit more about the work that you're doing and the role of the collaboration between oncology and primary care?
Certainly can. We have 30 clinics across 7 counties that we have primary care clinicians through Duke that are working collaboratively with us. Through cancer screening, we're doing a lot of projects in prostate cancer screening, colorectal cancer screening, lung and breast cancer screening. Through managing comorbidities of patients that are on cancer therapy. And when I mean comorbidity, that means health problems apart from the cancer, things like high blood pressure, cholesterol problems, diabetes, et cetera, and then how to make the handoff after the completion of therapy. The biggest part of it is just relationship building. We've worked with each of the different clinics. We've worked with the leadership of Duke Primary Care in both developing these initiatives as well as implementing them. The study that I'm most excited about, which we should start enrolling possibly this week, is called the One Team Study, the large $3.5, almost $4 million study funded by the National Cancer Institute, which is really intended for us to help patients day one of their diagnosis with breast, lung, colorectal, endometrial, head and neck, or prostate cancer, that when our patients are diagnosed with early stage disease, the likelihood is that they're going to do well with their cancer therapy. And their likelihood of dying from a heart attack and stroke actually exceeds that of dying from the cancer. That's surprising to a lot of patients. So in this study that has both primary care and oncology providers working together as one team, along with our behavioral scientists and our population health scientists, is to make sure that the primary care provider knows that managing the blood pressure, the cholesterol, and the diabetes of this patient is their job, while our oncologists are focused on the cure of the cancer. Not one or the other, but we're working together as a single team. Hopefully through that process, our primary care providers will also get more familiar with what the patients are going through from the journey, because they're part of the team day one, not 5 years afterwards on there. But I think that that's just an example of the sort of things that we're trying to do to get that message out and communicate between the two types of providers with the patients right there in the center.
Thanks, Kevin. And can you speak a little bit more to that? I know oftentimes when people start their cancer treatment, the primary care provider sort of falls to the wayside, and their oncologist is their primary treating physician, if you will, through their whole cancer experience. Can you speak to a little bit more about the importance of collaborating with the primary care provider during treatment and the importance of managing comorbidities during that time?
I certainly can. Again, that's kind of the essence of the One Team Study. And I'll use an example of a patient that I saw, continue to see, that our breast service referred to me a little while back. A patient was diagnosed when she was in her early 40s. She was treated with 2 therapies that can be bothersome to the heart. We call that cardiotoxic. She did great through her cancer therapy. She saw a wonderful breast oncologist, surgeon, and radiation oncologist. I can imagine the conversation each time was, are you going to your primary care provider? And she had PCP outside of the system, and they're going, yes, he's taking care of everything. Going to the PCP, are the oncologist taking care of everything? Yes. When I first saw her 5 years after her diagnosis, had been treated with 2 medications that could be harmful to her heart. She had high blood pressure the entire time. I could plot out every one of her blood pressures from the cancer center. And here she is, not horrible high blood pressures, but elevated above what they should be. Great oncology team, well-meaning PCP, neither were communicating. What our goal is that we really do communicate and manage the blood pressure, manage the anxiety, manage each of these issues all the way through, not 5 years later, but from day one. So that simply is an example that I think illustrates the direction that we're going with a lot of our initiatives.
Thank you, Kevin. That's really helpful. Lisa, we have some questions coming through about lymphedema. Can you talk to us about lymphedema and what are some techniques that your team members recommend for patients and how they would access those?
Sure. So the standard of care for lymphedema, the overarching term for all of it's called complex decongestive therapy. And what that is, it's comprised of 4 major components. One is a manual technique called manual lymph drainage, which helps facilitate the circulation of the lymphatic system. Oftentimes when people have lymph nodes removed, their lymphatic circulation doesn't quite move the same way, and this sort of reroutes the fluid around the area that it may pocket into. Particularly, an example in a breast cancer patient would be the adjacent arm, or if they had a lumpectomy, the remaining breast tissue itself. For people who have swelling in an arm or a leg, there is specific compression bandages that can be applied to the limb to further help facilitate that lymphatic circulation and redirect the fluid. Exercise, I sounds like an old harp here today, but exercise is actually a very key thing. The most current research regarding lymphedema management strongly emphasizes that the compression wraps and the exercise are 2 of the key pieces to really getting a reduction in swelling in a limb. So that's something we want to focus on. And then the other piece is skin care. So there's always a concern that if you get a scrape from working in the garden, or you bump your arm, working in the kitchen or some such, that any opening can cause an infection, which infections can create inflammatory reactions, which the concern is that can lead to more swelling problems. So we talk a lot about how to manage those situations so you don't have secondary complications from a minor first aid kind of injury. And then the goal is to get the patient, because lymphedema is considered a chronic condition, because unfortunately, we don't really regenerate lymph nodes. There are lymphatic surgeries that are available, and we do provide them here at Duke. But they tends to be something that's really an option for someone who has responded to more conservative treatment. But we don't, unfortunately, regrow lymph nodes. So we need to teach patients how to manage this change in their system long-term. And so the use of various compression garments and or compression pumps are sometimes recommended depending on its presentation. So for my team, there's many different options we can provide, but the treatment is tailored to the individual presentation of the patient that's sitting in front of us. There's lots of tools to use, but it's not a one-size-fits-all approach to how we take care of each of our patients.
Thank you. We have a few more questions. Perhaps Lisa and others continue on as well with the theme around PT engagement and survivorship care. A common question that people have is around sexual health during treatment and post-treatment. What is the role of physical therapy when it relates to patients' sexual health?
Great question. So we're fortunate enough here at the Cancer Center that we have a female sexual health clinic for cancer survivors. And basically it's physical therapy is part of a multidisciplinary approach, that includes psychology, whether it's a licensed marital family therapist or in certain specific cases, possibly consulting or getting a referral to a sex therapist, physical therapists. And I often jokingly say that physical therapists are sort of the biomechanical experts of sex, in that we are very interested in how your bones, muscles, and body move so you're able to enjoy the sexual activity of your choice. Sometimes after specific treatment interventions, you don't move your body the same with sexual activity, and you need some help or suggestions so you can enjoy the things you enjoy to do with your partner. And then the other component of that group, we also have a pharmacist who can talk about side effects of medication that may reduce your libido, because sometimes people will report that after being treated for cancer, they just don't feel as aroused as intensely or as often as they used to before their treatment. So we can talk about that and come up with alternative strategies. For women specifically, one of the things they often complain about too is vaginal dryness, particularly our patients who undergo therapies to reduce the amount of estrogen in their body, because unfortunately estrogen is one of the nutrient sources for their tumor, feeds their tumor. And so we have different strategies to how to combat that. And also making sure that your pelvic floor muscles, which are the muscles around the entrance of the vagina and rectum, are working appropriately so you can engage in any type of sexual activity that you choose of without experiencing pain during that. For our gentlemen, I don't want to forget our male cancer survivors. With our prostate cancer patients, the physical therapists often do some education regarding penile pumps when appropriate, based from the physician. And similarly, sometimes their treatments make it the positions for sex that they enjoy the most difficult. So we'll come up with the same type of adaptive strategies. That's basically, I'd say, an overview of the role for the physical therapist in the sexual health clinic. And the good news is we're going to be offering the sexual health clinic at our Macon Pond location starting the end of this summer. So we'll have 2 locations to provide this service in the near future.
Diane, can I add something? I think it's important as healthcare professionals that we normalize this, just as a patient would say they have mouth sores and all these other things, that we make it easy for them to ask questions about their sexual health. And we need to ask those questions so that we can connect them to the LISAs, because unless we make those referrals, then LISA doesn't have the people to help. And oftentimes, I think as a professional, we think about all the other health things instead of sexual health and some of the other things that are important to people. And so we have to make that not so intimidating for our patients so that they can ask questions and feel holistically healthy. And that's a challenge for me sometimes, but I'm learning how to do that because I know that is one thing that's important to our patients.
Thank you very much. We have other questions about some specific experiences that people have had with what we referred to earlier as chemo brain or cognitive changes that they're experiencing or memory changes. And that's probably in the space like sexual health, that it might be things that people might not think to bring up to their care team, or might feel embarrassed about changes they're experiencing, or not know what to attribute it to. Does anybody have any recommendations of available strategies or team members that people should connect with in regards to changes in memory or concentration that people are experiencing? And I know, Kevin, you mentioned earlier about our psychology team members, and Curran, I'm curious, you as well, if you have specific suggestions for the person asking the question.
While people are thinking of responses, I'll also reiterate what Lisa said. Our occupational therapists have a wonderful, we call it cognitive remediation, but it's really helping with that chemo brain on there. One of my colleagues at Sloan Kettering did a study that I found fascinating that explains to our patients a lot of times what they're feeling, what they're dealing with. He looked at identical twins, and he was doing functional PET scanning showing the brain activity with simple to more difficult or complicated questions or things for them to solve. And it has one slide that he shows a woman that had breast cancer, went through her chemotherapy, and then her identical twin who did not have it. Again, starting with very simple questions and going to complex questions. What he showed is that the activity of the brain for the cancer survivor is just lighting all up. A lot of energy requiring to be able to answer that question. Not all the questions are right, but you can imagine at the end of the day, the amount of fatigue that concentration, that focusing has. Simple things that I always tell patients before we make a referral is start with the easy ones. Don't multitask. Shut everything down, turn off your cell phone, turn off your email. When you're working on a task, be in a quiet environment where you can focus, and that allows you to do better, because multitasking is one of the things that people lose or really competes with their ability to stay on task. On there, use sticky notes, just little simple, helpful sort of things like that to be reminders on there, or the notes on their phone, something along those lines on there. Use a second person to come into your visits to hear what the doctor or the provider is telling you, and to be able to take notes and things of that nature. And then I often will send kind of a summary to my patients of what we talked about. So these are just things to help, simple little things, in addition to what Lisa mentioned with the cognitive remediation.
I would also just add to Dr. Effinger and just cognitive strategies. We are not used to using them as often because we feel that we would remember things and things like that. A lot of it also comes from not being upfront about it to ourselves. And so using these cognitive strategies, whether be it note taking or having doctors write a very sort of precise, specific patient instructions in their visits goes a long way. Using actively participating in relaxation techniques, using phone-based apps like Headspace, giving brain rest, what I say, like taking short breaks during the daytime to just not do overtasking yourself goes a long way. And seek out help. You know, if you have difficulties with at work or things like that, seek out professional help in terms of neuropsychological evaluations if that's needed, and potential pharmacological treatments. There are treatments that are out there that are evidence-based, and they often can be life-changing in situations in which it causes a lot of distress. I would also like to mention that if these issues are not addressed early on, it can also just bleed into other areas of life, causing a lot more anxiety, depression, problems with sleep, and things like that. And so addressing these problems and being upfront about it and open about it goes a long way.
And just from a practical standpoint, Shan, I'd like to add that if any patient can contact any physician that works with them and ask for an occupational therapy referral, put into the Duke system. We have multiple outpatient locations in both Durham, not Duke, Durham County and Wake County to provide OT services. So hopefully there's a location near anyone who's interested and they can seek the care they want.
Thank you, Lisa. Paige, we had a question come through about the role of vitamins and supplements during treatment as well as post-treatment. Is that something that you can comment on, or do you have advice for people?
Yeah, so that's one of the most common things that I'm often asked because they think, well, there's that kernel of advice of like, if something is good, then I should take a lot of it and it'll be super good. But that's often not the case, especially if you're receiving radiation and certain chemotherapies. If you are taking individual supplements, such as what's been studied, things like vitamin C or turmeric supplements or green tea supplements. Yes, these things are good when you have them through food in the diet, but in super amounts and supplementation, it could actually, not allow the chemotherapy or the radiation do the job that it needs to do in reducing that tumor burden. And also in the United States, it's very important to remember that supplements are not regulated by any government agency. Some more quality supplement companies will send them for a third-party test, but a lot of them, you're just buying, you don't know if it says it's giving you 500 milligrams of vitamin C. It might be 300, it might be 800, we just don't know. But I always encourage everybody, try to get it through food. Our body utilizes the vitamins, the minerals, the phytochemicals in food much better than you ever would in supplement form. But if you are concerned about being deficient in certain vitamins, like maybe you're a vegan and you've just recently gone through cancer treatment and you've had gastrointestinal issues, ask to have certain vitamins like B12 or B6 checked and see, and then if you need to be supplemented, that's something that your provider can recommend for you, specifically just for you based on your labs.
And can I add that we also have the integrated department at Duke, and so they can also help guide our patients in the correct supplements, or if they need supplements at it.
Thank you. And we have a couple final questions. I know we only have a few minutes left, but I want to get in as many of these last couple questions as I can. Kevin, somebody wrote in about a younger person diagnosed with a type of cancer that's typically more commonly seen in older patients, and they're feeling very alone. What would you recommend for younger adults who are facing cancer in terms of their care as well as that social component?
You should have answered that question, Cheyenne. So
I'm the moderator.
we have a wonderful, vibrant teen and young adult program with oncology providers and behavioral scientists and other providers helping out from both the pediatric and the adult side. And that's a very common problem. And our goal is to be able to connect people with peers that are going through similar experiences, to be able to address the things that are unique to where they are in their life trajectory. Pardon me. And so reaching out to our supportive care program, we can plug you in with the teen and young adult program with Coleman Mills and his staff.
Thank you, Kevin. I also would be remiss if I didn't mention that Paige is actually going to be doing a demonstration and live Q&A later today at 1:30. So if you're not already registered for that, make sure to go on the DukeCancerInstitute.org/survivorship day page, and you'll get the information for participating in that. I'm just scanning to see if there's any other final questions. Any other questions that I haven't asked you that you thought I would, panel, before we start wrapping up? Any final words of wisdom? Val, you're always a good final words of wisdom.
But I just wanted to say more about our support group, whether you consider yourself a survivor, after your initial diagnosis or when treatment is done. I think that support groups are really good in that there are people that can share some of your same concerns, and you're not frightened to say your wildest dreams because they get it. And so I can't say enough about our support groups. We have one for patients and for caregivers, and it's just so valuable to just be able to share and not have to worry, and not discuss your concerns, with that cancer patient that you're afraid to talk to about, or the cancer patient that's afraid to talk to the caregiver. So again, we just have wonderful support groups, and we need to use them, and people need to utilize them. So that's my final statement.
Thank you, Valerie. Well, I wanted to thank our panelists for the information you have shared with us today. It's been incredibly helpful. Thank you to our crew behind the scenes. And most importantly, thank you to our attendees for your thoughtful questions today. As I'm sure you could tell from today's panel and discussion, our team of cancer support and survivorship specialists have a wealth of knowledge that they use each day to provide care that is specific to each patient's needs. They're passionate and dedicated and work collaboratively to help those facing cancer. Each of the services discussed today and many more are available through the Duke Cancer Institute's Supportive Care and Survivorship Center. And you can find more information on our website, which is dukecancerinstitute.org/supportive-care, or by calling 919-684-4497. At the conclusion of the event, we ask for your feedback in a brief survey, which you will be redirected to in your browser at the end of the webinar. We also will provide the link in the chat for you. So stay online for just a moment to provide us with your feedback, as it's very helpful for us in planning future events. Thank you for participating in today's webinar on cancer survivorship, living with and beyond cancer.